Good afternoon. This is the first presentation within the new year. Happy New Year. And I'm going to discuss how to reach the diagnosis of a case of hypercalcemia. So I'm going to discuss hypercalcemia through cases and messages. So start with the squeeze of the American Journal of Kidney Disease. The case has hypercalcemia, acute kidney injury, and esophageal lymphadenopathy. Let us start with the first question. How does hypercalcemia lead to acute kidney injury? Here we find creatinine is 2.7 from 1.4. So the answer is hypercalcemia leads to vasoconstriction of renal vessels and reducing kidney perfusion. Secondly, calcium can be deposited within the medulla of the kidney, and this is associated with reduction of aquaporin 2 and polyuria. Thirdly, hypercalcemia inhibits sodium-potassium 2-chloride cotransporter within the thick ascending limb of Henle, try to reduce calcium reabsorption, but because of volume depletion, calcium reabsorption even increases. So this is a vicious circle. This is why when we treat acute hypercalcemia, the first step is to give IV fluid to cut short this circle. If this is the full pattern of laboratory investigation of the case, what is your diagnosis? Before discussing the diagnosis of this case, let us go step by step for the differential diagnosis of hypercalcemia, how we tackle and we pick up the diagnosis. To start with, the most common causes of hypercalcemia are either malignancy or hyperparathyroidism. This is why we start with measuring intact parathormone. We may find it high or inappropriately high because we expect that hypercalcemia through feedback mechanism inhibits parathormone. So we may find it is high or inappropriate high. In this scenario, we should measure urinary calcium excretion and fraction excretion of calcium. That is maybe low, less than 100 milligram calcium per day, or fraction excretion of calcium is less than 0.01. If this is the scenario, an appropriate high beta-H with hypercalcemia and low calcium in urine, we are either within the diagnosis of familial hypocalcuric hypercalcemia or neonatal severe hyperparathyroidism. Suppose that you find high beta-H and high calcium excretion. So here we are within the diagnosis of hyperparathyroidism, primary or tertiary hyperparathyroidism. If we measure beta-H, intact beta-H, and the result is low intact beta-H, less than 10 picogram per ml, here we measure beta-H related peptide. If it is high, this denotes malignancy, humoral hypercalcemia of malignancy. But if it is low, we should shift to vitamin D. So measuring vitamin D, 25 hydroxyvitamin D3, and active vitamin D, 125 hydroxyvitamin D3. Why we measure these two hormones? Because if we measure these three hormones, we will have three possibilities. High active vitamin D and suppressed native vitamin D. Why? This may be due to calcitriol treatment, because calcitriol is active vitamin D, or granulomas. Why granuloma is associated with increasing active vitamin D? Because granuloma secretes 1-alpha hydroxylase from the macrophage. Within the granuloma, 1-alpha hydroxylase is secreted, and there is a great difference between 1-alpha hydroxylase secreted from macrophage and the native natural 1-alpha hydroxylase secreted by proximal convoluted tubule. The major difference is 1-alpha hydroxylase secreted by macrophage is not following the regular and the usual feedback with calcium, so it is not suppressed. So it stimulates conversion of vitamin D into active vitamin D. This is why we will have high active vitamin D and low vitamin D. If we find high both native vitamin D and active vitamin D, this is the case of vitamin D overdose. If both of them are low, here we are dealing with other etiology rather than hyperparathyroidism, malignancy, or vitamin D related. This is maybe local osteolytic lesions, milk alkali syndrome, immobilization, thyrotoxicosis, vitamin A intoxication, or other causes. So this is the panoramic view of differential diagnosis. We should measure intact beta-H, followed by assessing calcium in urine, and then beta-H related peptide. If there is no answer from all these, we should think of measuring active and native vitamin D, and to both the clinical, laboratory, radiological, and this all these together to reach the diagnosis. Back to the case. Here beta-H is normal, so we don't have hyperparathyroidism, and it is to the low normal. Beta-H related peptide is suppressed. This is not a malignancy, and the radiological workup showed no malignancy. Active vitamin D is even low, and vitamin D is native vitamin D is normal. Thyroid is normal. Multiple myeloma is investigations related to multiple myeloma are negative, so we don't have malignancy, we don't have hyperparathyroidism, and we don't have hypervitaminosis D, so, and we don't have granulomas, so we are left with the milk alkali syndrome. And because this patient was treated with antacids, so milk alkali is, it changed from milk alkali to calcium alkali syndrome, and how to pick it after excluding all other etiologies, malignancy, hyperpara, and the patient has metabolic alkalosis with acute kidney injury. This is a CLO. And if we diagnose milk alkali or calcium alkali syndrome, we stop all the antacids and the calcium intake and give IV fluids. That's all. No need to give bisphosphonate or denosumab. Bisphosphonate and denosumab are treatment of bone resorption. Denosumab is a monoclonal antibody that inhibits rankle. Rankle is a ligand secreted from osteoblast that binds rank on the osteoclast with subsequent stimulation of osteoclast. All these treatments are reserved for the chronic management of hypercalcemia. So how to treat acute hypercalcemia? This is the different axes of management, promoting calcium excretion through giving normal saline, because normal saline improves the GFR and promotes calcium excretion. After volume repletion, we can give furosemide, because furosemide in this scenario will inhibit calcium reabsorption from the thick ascending limb of Henle. If we don't replete the blood volume, what happens? More and more hypercalcemia. Treating bone resorption by giving calcitonin, bamidronate, zolidronate, and gallium, all of these drugs are given parenterally, and the mechanism is to inhibit bone resorption. Decreasing cell absorption by giving steroids, prednisone, that inhibits gut absorption, and the last resort for the cases with severe hypercalcemia, severe neurological abnormalities, and the presence of renal failure, may be hemodialysis using dilazate bath containing low calcium. So this is the treatment of acute hypercalcemia. Treating chronic hypercalcemia in avoiding calcium and giving bisphosphonate oral, denosumab, even chloroquine. All these drugs can help for the management of the case and etiological treatment. So here I would like to refer to a book this is the renal drug handbook. All nephrologists should have this book. Suppose that you would like to know zoledronate, just like this, and do search. You will reach the drug. This is the zoledronate, zoledronate. Because it is very important for nephrologists to know the pharmacology of the drug, protein binding, dialysability, precautions with renal impairment. So all these informations can be at your hand if you go to the clinical use, hypercalcemia of malignancy, reduction of bone damage, advanced malignancy, osteoporosis, and this is the dose in normal renal function, pharmacokinetics parameters, metabolism, those with different degrees of kidney function. So I recommend this book for all of you. This is another case. This is a case of breast cancer, and denosumab was given for 5 years, and after withdrawal of denosumab, the case was complicated by acute hypercalcemia and excessive bone resorption. What is the diagnosis? Here I want to focus on the message from this case is the rebound hypercalcemia and bone resorption after withdrawal of denosumab. This is why we should be cautious with withdrawal of denosumab, and we may think of gradual withdrawal, and even if the hypercalcemia occurred, we may think of bisphosphonate. This is an exercise for all of you. Please stop the video here. We have different conditions that can lead to hypercalcemia, and these are the biochemical testing. I want to just to refer it is increasing or decreasing or unchanged, undetectable, normal, or no significant changes. Just for all these biochemical value parameters, I want you just to exercise, to have this exercise. So please stop the video here and put your answer. This is the answer of the question. Another case, this is a 62-year-old man was brought to emergency department with altered mental status. Physical examination showed a confused, well-developed male with labored breathing. He was intubated to protect the airways. His blood pressure was 130/78 with a pulse of 100 beats per minute, except for lower extremity ulcer, which was wrapped with a bandage containing white powder. The rest of examination was otherwise normal. His laboratory results were as follows. Again, here, this is the hypokalemia, acute kidney injury. Calcium is 9.2, but albumin is 2.7, so it is above 10.5. So this is the hypercalcemia. And this is blood gases. Bicarb is high, 53. And after repletion, again, the calcium in urine is 150 milligram per liter. Chloride is less than 10. And after vigorous hydration with normal saline and potassium supplementation, electrolytes, creatinine, and pH improved. Blood pressure rose, and the patient was successfully extubated. His intact parathormone and vitamin D were low normal. Which one of the following is the most likely diagnosis of hypercalcemia? Please apply the principles that we discussed together. Is it thiazide? No, because calcium in urine is normal. So it is not reduced, and the chloride is not within thiazide diuretics, and the sodium in serum is high. So thiazide is unlikely. Occult malignancy, PTH related peptide, and radiology are within normal, but it should be excluded. Familial hypocalcuric, there is no hypocalciuria, so it is not familial hypocalcuric hypercalcemic. Sarcoidosis, it is not sarcoidosis because there is no manifestation, plus active vitamin D is low normal. So we are left with hypercalcemia related to calcium-containing medication, milk alkali syndrome, which was the powder applied to the ulcer, because this is the secret. So baking soda may be ingested or may be put in bandage. So this is the milk alkali syndrome. Again, stop this powder, give IV fluid. That's all for treating hypercalcemia. A 45-year-old female patient was referred to the renal clinic for evaluation of hematuria and frequent urinary tract infection. She was found to have renal stones, and during the workup, ABTH level is elevated 96 picogram per ml. The question is regarding the ABTH assay, which one of the following statements is false? The first generation measure either C-terminal or mid-region of the BTH. BTH is composed of 84 amino acids, and we have N-terminal and C-terminal. The second generation assays measure intact 1 to 84, and other degradation fragments 7 to 84. The action of intact BTH are different from 7 to 84. The ratio of 1 to 84 to 7 to 84 discriminates low turnover from high turnover bone disease in dialysis patients. Third generation measure the biointact 1 to 84 and not 7 to 84 fragments of the BTH. What is the best answer? This is the very interesting review editorial about the BTH assays. First generations, it is a polyclonal, and it detects many fragments, so it is obsolete nowadays for diagnosis of BTH. For second generation, yes, it picks the total 1 to 84, but also detects 7 to 84. So this is the, and for 1 to 84 and 7 to 84, there is a great difference. So the 7 to 84 inhibits bone, and 1 to 84 stimulates bone. So there is a great difference between them. So if we measure intact BTH by second generation, and the main composition is 784, and we treat this case with the phosphate binders and calcium mimetic, in this scenario, this may precipitate a dynamic bone disease. So we should know this second generation assays detect intact molecule and C-terminal 784. Third generation assays only detect the full molecule from 1 to 84. This table summarizes advantages and disadvantages of different assays of BTH. First generation, the first method, opened the door for more specific generations. Now it is obsolete. Second generation, the most widely used, less expensive, adopted by current clinical practice guidelines. However, they cross-react with C-BTH 7 to 84, and there is a wide range of inter-method variability. This is why we should concentrate on the method intact BTH is by second generation, and not only one reading, but on the trend. This is more better than focusing on one reading. Third generation assays, direct measurement of biologically active BTH doesn't cross with CBTH, may correlate better with mortality. But this third generation assays are more expensive, less widely used, not adopted by the current practice guidelines. What about the measuring the ratio between intact BTH and CBTH 784? This may correlate better with bone histomorphometry and may give accurate information for both biologic active and inactive hormone. However, this is a more expensive modality as it requires utilizing second, because in second we measure both intact and CPTH, and third that measure intact PTH alone. So it is more expensive and with conflicting evidences about its diagnostic and prognostic value. So first generation, yes, it measure C-terminal and mid-region. Second generation, yes, it measure intact and C7 to 84. The action of intact PTH is stimulatory to the bone, and this is inhibitory, yes. And the third generation measure biointact alone, yes. So this is a debatable action. So the false statement is number 4. The ratio doesn't discriminate low from high turnover. It is a debated issue. Another case from American Journal of Kidney Disease quiz on November 2017. This is the radiology workup here, skull, stenotic lesions, and here hyperintensity with MRI. The question is, in the first case, we discussed the effects of hypercalcemia with acute kidney injury. Here, what are the effects of hypercalcemia on neurological system, musculoskeletal, cardiac, and gastrointestinal? This table summarizes pathophysiology and features or symptoms. Regarding nervous system, hypercalcemia leads to cerebral vasoconstriction, endothelial dysfunction, and systemic inflammation. Influx of calcium into the neuron due to high calcium concentration in the extraneuronal environment, resulting in release of neurotransmitters into the synaptic cleft, with subsequent posterior reversible encephalopathy syndrome, psychosis, decreased concentration, confusion, stupor, and coma. Musculoskeletal system, increased neuromuscular excitability and leading to muscular weakness and weakened reflexes. For the cardiovascular system, myocardial action potential shortening by acute hypercalcemia, QTC shortening leading to high takeoff of ST segment, QT interval shortening on ECG, bradycardia, hypertension, ST segment elevation mimicking myocardial infarction. Gastrointestinal system, calcium deposition in the pancreatic duct and by activation of trypsinogen by calcium within the pancreatic parenchyma, increased secretion of gastrin by calcium, autonomic function abnormality, and decreased smooth muscle tone, with subsequent peptic ulcer disease and constipation. So this is the pathophysiological effects of hypercalcemia, and these are the reflection on systems. This is the last question. A 30-year-old man with HIV AIDS is found to have hypercalcemia, which is brought to be medication-induced. Which one of the following drugs is not associated with hypercalcemia? Vitamin A, omeprazole, silicon, lithium, chloroquine. Vitamin A leads to bone resorption and hypercalcemia. So vitamin A is one of the causes, intoxication is one of the causes of hypercalcemia. Omeprazole leads to hypocalcemia, but it may be complicated by granulomatous interstitial nephritis with release of 1-alpha hydroxylase from macrophage from the granulomatous interstitial nephritis, so it may lead to hypercalcemia. Yes, the major effect is hypo, but may lead to hypercalcemia. Silicon, we may have siliconoma, granulomas related to silicon implant, so this is granuloma means hypercalcemia. Lithium can stimulate PTH with resultant hypercalcemia. So the first 4 drugs may be associated with hypercalcemia. Chloroquine suppresses vitamin D. This is why chloroquine may be used for treating chronic hypercalcemia. The last message, we'll continue learning, and this is my symbol in this year. A doctor is a student till his death. When he fails to be a student, he dies, as Sir William Osler stated. Thank you very much for your good attention, and I'll be happy if you have any questions to send to my email. Goodbye.